Hi, thank you for joining us for our Lunch and Learn Meet Your Domestic and Family Violence local link. My name is Phoebe James, and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands we are all meeting on today and pay my respects to elders past, present, and emerging, and any First Nations people joining us today. Just wanted to mention this session is being recorded. The recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. If we have time for Q&A, it will be at the end, so please do send through your questions. We will actually have Shannon Richardson, who is a pilot program manager with the Primary Health Network, in the background working through those questions as they come through. At the end of this, there is an evaluation that needs to be completed, and I'd be eternally grateful if you could fill that out for me. Today, presenting for us, we have Dr. Alison Lancey, who's a GP and the RACGP Deputy Head of Training for the Hunter, Manning and Central Coast region. Alison is passionate about delivering high-quality practical education to GPs. Alongside her, we have Alana Ratton with us today. Alana is a DFV local link for the Oxley region. Alana is a DFV specialist and sits within the Women's Domestic Violence Court Advocacy Team at Tamworth Family Support Services. I will now hand over to Alison to start us off.
Hi, thanks very much, Phoebe. I hope that everyone can hear me. Please let me know, Phoebe, if you can't. So thank you very much to the PHN for inviting me to talk today. I've been doing some education around lots of GP practices in this area, and I will be coming up to the Tamworth region in probably about April to do some more. But we'll talk about that as we go. So part of my role here today is to actually talk about the pilot that is being conducted in this region and in your region as well. So Safe and Healthy, so it's a Commonwealth funded pilot. So it's giving free training to primary care professionals with the aim to increase the confidence and awareness of those of GPs, of the nurses, of your practice staff, to spot the signs of domestic and family violence and abuse, to start the conversation with your patients, and then to link for support. And it's amazing that we've got Alana here today so that you can actually put a face to that link as well. Now, I think this program is amazing. So I met the PHN team last year when I was presenting our domestic violence session to our registrars for the Hunter Manning Central Coast region. And so that's why I've been doing some more work with them since then. Previously, I felt completely helpless when I was working in general practice when you had a patient that did disclose that they had experienced domestic or family violence and abuse. And this program, I think, is amazing because it gives you now a contact, someone that you can talk to, someone that can link, someone that follows up with the woman and the family. You've got case management, you've got all sorts of things that are happening. So this program is amazing. And so the whole point of this is just a snapshot of what's happening and why it's important. And so to put a face to the name so that you can meet Alana for the local Oxley region. So as Phoebe was saying, if you've got questions, please put them in the question box, or you can email Alana as well, and we'll have her contact later on. And if your practice would be interested to do more of this training, then we've got contacts for that too as we go. But firstly, the reason why this pilot has been occurring is because it's domestic and family violence and abuse is actually a public health issue. So for women, when you're looking at the highest burden of disease for women aged 18 to 44, domestic and family violence and abuse is actually the highest risk factor for ongoing chronic disease. And that's higher than any of the lifestyle things, so alcohol, tobacco, drug use, inactivity, obesity, sexual abuse, workplace, all of those sorts of things. And so, it's a 5% burden of disease comes from domestic and family violence and abuse, and it's a huge cost to the public health system. So we're looking at about $22 billion just in general across the community that it costs. Is the estimated cost of violence against women. Looking at violence, abuse, stalking. So this is old numbers, so 2015 to 16. And we know with COVID that that the rates of domestic and family violence and abuse massively increase. So that number is probably higher now. And certainly just for the health system, so we're looking at primary care and the hospital system, about $1.4 billion it contributes to costing. And certainly, so the whole, the whole purpose of this is for us to be educating as a public health issue, but also, so when we come in, we provide education to your practice staff as well, so your reception staff, your admin staff, as well as your nursing staff and the GP. So we're not just looking at it from a medical perspective, we're looking at it across the community. And certainly if you've got a high number of Aboriginal or Torres Strait Islander women in your practice, then certainly we know that the disease burden of domestic and family violence is much higher for those groups, and particularly for other minority groups, refugees, looking at people with disability. So it's much higher for those kind of minority groups as well. So that's where we're trying to target. So why are we really focused on primary care? Well, in terms of disclosure, the person that you're most likely to disclose to is obviously going to be a friend or family member to start with, but the second person that you're most likely to disclose to if you have experienced current or previous partner abuse is your GP. So that's why we're pushing this education to the GPs, because you're going to be the first port of call. And certainly if you are a full-time GP, the statistics show us that you'll see 5 people each week that are experiencing or have experienced domestic and family violence and abuse. So when we've done this training with our GP registrars, a couple of years ago, we had a registrar provide feedback to us that was like, I don't see why I have to do this training. I'm a male GP, and I don't see a lot of women, and the people are not going to disclose to me. Well, that statistic is incorrect, because if you're working full time, and many male GPs are more likely to work full time, and so you're more likely to see these women. And what we know from the statistics is it doesn't matter about the gender as well of the doctor that is being disclosed to. So women are very happy to disclose if you're a male, if you're female. It doesn't matter. It's about asking. So that's why we're kind of pushing this and really encouraging you to be looking on the lookout for it. So in terms of the primary care response, I think it's really hard to not feel overwhelmed when you're the GP and someone does disclose, just because there's lots of other stuff going on. You're time poor, you've got 15-minute consults that often comes at the end of the consult. You have to make a decision about, if I'm going to run late now, do I need to deal with this right now? Can I get this person back? And a lot of these sorts of things we're going to talk about in additional training. But certainly the big thing in general practice is about spotting the signs. And you guys are, I'm sure, are very aware of what the signs are. And I think sometimes it's hard. It's very easy to just go, I don't want to ask. And certainly it's finding the times to ask those questions as well. And so certainly we talk about, when you might be asking, and if you've got antenatal consults, if you're doing cervical smears, if you're doing women's checks, if you're doing any of those kinds of things, they're just nice, obvious points to be, asking the question. But certainly then you've got your other signs that you might see, the more obvious ones, when someone presents with a black eye or fracture or a story that doesn't match up with an injury. And then you've got the more subtle things that you might spot, the difficult patient that may have some mental health concerns that you're not getting on top of, that's got quite a lot of emotional distress, that is very inconsistent with presenting for appointments, who might present with quite somatic type symptoms that you can't find an answer to when you do investigations. So a lot of those can be some of the signs. And then it's about starting the conversation. And that can be as simple as, in those kind of women's checks, in the situations where it feels natural to ask the question, you can say, I ask all women while I'm doing these checks. I always like to ask people how are things at home. A really simple question like that can start the conversation. In the patient that you just can't get a handle on what's happening, they're presenting with lots of symptoms and you're not finding any answers, a good question in that situation can be, is there anything else going on in your life that might be contributing to this? Um, and, those kinds of ways that we can ask those questions and start the conversation, we can talk about when we do the full training. And this is just a taster today. And then linking for support. So this is the moment where you go, I feel very overwhelmed by this. I'm not quite sure what to do. Who should I talk to? This is when you can link in with your local domestic family violence and abuse link, which is Alana, which is awesome. And she's going to talk in a moment as well. And certainly this early intervention, it starts with us asking, it starts with us just being aware and having it in the forefront of your mind, because it is everywhere. And to be honest, since I've started doing this training, I've become much more aware of how much it has affected so many of the people in my life, from my immediate family to my friends, to my friends' partners, um, from my best friends, all those sorts of things. It's very, very prevalent in our society. And I think we need to bring it to the forefront of our brain, and how much that this contributes, particularly with kids. I'm certainly seeing that a lot in kids being diagnosed or being investigated for ADHD, for, kind of a diagnosis, but a lot of this is coming from domestic violence or previous abuse and things like that. So I think, the whole point of this pilot is to bring it to the forefront of our conversations with our patients and in our minds, and to make it a more natural thing to be asking of all of our patients. And certainly the conversation. So, like I said before, it's about asking the questions. So if there's something very simple, how are things at home? How are you getting on with your partner? And, having that very gender neutral way of asking about it too, not assuming that it's a male partner or, because obviously this happens in same-sex partners and relationships as well. And I really like this question. Is there anything else happening in your life that might be affecting your health, that might be contributing to the way that you're feeling? Um, and then you've got the more specific things. So, sometimes I fight with my partner, sometimes he gets angry. Okay, now you can ask the direct questions. What happens when your partner gets angry? Has he ever, been like this with your kids? Sometimes partners may use force or may be violent. Has this ever happened to you? So asking those questions are really important. They're the more the direct questions. And then it's just about listening and validating that as well, because a lot of people don't like to speak up. They're afraid of speaking up because they're worried about not being believed. So it's about, I thank you for sharing that. I understand that must be really difficult. I believe what you're telling me. I care. I'm here for you. I'm here to support you. And really saying that out loud, I think is really important, and validating that as well. I'm so sorry that this has happened to you. Everyone should be able to live safely at home. This is not your fault. Thank you for telling me those sorts of things, that validation that this is not okay, and that you understand that what's happening to them is not okay. And then the action step is generally the fourth one. So can I ask you some more questions to understand, if there's any other risks? I'd like to talk to you about a safety plan. Is this okay? I would like to link you to a special support service. Is that okay? In terms of linking with the support person, and Alana might talk about this as well, if you really feel someone is very high risk, and certainly the risk assessment is part of, I'll show you that in a moment. If you really think that someone is really high risk, that, they've just got a partner with a previous history of domestic violence, or is just out of jail and they've been stalking them, and that you're really worried for this woman going home and they're really worried about their safety, and you think that they're high risk, and they're going, no, I don't want you to refer me, I don't want you to refer me on. You can actually still contact the link and talk to them about this patient. So you are covered by legislation to do that. And these are the sorts of things that we'll talk you through when we do the longer education with your team and the doctors in your practice, because there are nuances about referring and things like that as well. So this is the action plan, and now the PHN have created this so that it can be downloaded into to best practice and into medical director so that it will auto-populate with a lot of things. So it is quite small, so I do apologise, it might be quite difficult to see, but the first page is basically contact details, and it's got things on there like safe hours to contact the person and also things like additional contacts as well. Now, the second page is the risk assessment, and it's basically got 10 questions to help determine whether you think this person might be high risk. And then there's kind of the final page, which is some stuff that you can do with a patient plan. Now, if you don't get time to do all of this, if you don't get time to do the risk assessment, all that kind of thing, you can still refer this patient on. You can just complete as much as you can complete and send it on to Alana as well. So the Alana, I'm assuming you're the person that might be able to talk with the practices about how to upload this and that kind of thing.
Yes.
So I'm going to hand over to her now so that she can talk to you all about her role.
Thank you, Alison. Okay. So as was mentioned, I'm the DFB local link. So what that means is I work for WDV-CAS, or the Women's Domestic Violence Court Advocacy Service. And I'm like the go-between, helping the GPs and your clinical staff to connect your patients through to our service. So one of our lovely ladies here, one of my colleagues, would contact the patient that when we get the referral. And we do have like a time restriction on ourselves as well. So we do need to make contact with her within 24 hours. And we will then have a conversation with her. We'll assess the risk, we'll help her safety planning, we will link to appropriate services. So that might be parenting courses, it might be the staying home, leaving violence service. Maybe it's Homes North. So we'll just work out what is she needing and what can we assist with. Then we'll provide the advice and the support over the phone. And of course, if she's going to court, we'll also provide in-person court support as well. So we can also, we do let the clinicians know when we've received the referral that we're able to take it on. If we have tried 3 times and she hasn't answered our calls, we might get back to you as a GP and other clinical staff just to see if you can make that contact with her, because she may not be able to answer the phone coming from someone she doesn't know, whereas maybe having her doctor's office ring her, she might be able to take that call. So we might be getting back in touch for assistance such as those. So on the next slide, sorry, yeah. Yes, okay, very good. So these provide the details of how to reach myself and also my colleagues here in the Tamworth office. So we look after the whole Oxley Police District, and you can, after you've downloaded that action plan into your clinical software, you can then fax or email it through to us. If you are using medical objects, that would be great. We do have our medical objects number there that you can find us and send it through that way. But of course, if you want to ring us and discuss maybe something's going on and the patient hasn't consented to being referred to us, you can still give us a call and get some advice. And of course, under the 13A Act, the Violence and Crimes Act, if you deem her to be a serious threat, you can still refer her through to us without her consent. But otherwise, we do request that you obtain her consent first. And of course, we're helping women aged 16 years of age and over, and also her children. And it's, nowadays domestic violence takes any form, so we are able to assist ones even if there's no bruises or anything, but it's other things are going on, emotional abuse, financial abuse, all those kinds of things. We can help her with that. Thank you.
Hi. Okay, well, I am just going to give a plug now for the training. So like I said, I am actually coming up to the region. So I'm a Tamworth girl, so I know the region well be up there. So I'm going to be coming up probably April to try and come to around as many practices as would like to do the additional training. So we do 2 hours of training. The first one is targeted at your entire practice. So that includes your front of house reception staff, nurses, the doctors, anyone else that works in the practice. Basically, the aim is to talk about it as from a public health perspective. So thinking about it, how, you know, what you can do if someone does disclose to you, how the practice, you know, your reception staff might identify, might be able to talk with you if they identify stuff that's happening in the waiting room, or if they've got concerns about, you know, patient that's presenting, because they're your eyes and ears of your practice. And we aiming for this to be a whole of practice education, so that the practice can talk about how you might be wanting to you know, deal with this, I guess, in the future, thinking about, you know, how you'll handle, you know, running late, if there's kids there, if there's, you know, things that you see in the waiting room, all that kind of stuff, how it's documented. So that's that for the first hour. The second hour is very much targeted at the nursing and medical teams. And so that is going to be more kind of case study based, looking at how you might ask within your appointment time, how you would do the risk assessment, and the plan is, and I'm working on this at the moment, to be looking at that from a, you know, acute kind of patient that you need to sort out today, and from a, well, I've been seeing this patient for 20 years and I just decided today to ask the question and they told me that yes, they are experiencing this, and now what do I do? So, you know, there's obviously there's lots of different ways that it presents, but we're planning to sort of talk you through some cases. So I would really encourage you, if you're here today and you think, oh yeah, our practice would be really interested in doing that, you can definitely contact us on that email address that's on the screen now. If you can write that down, you can get in contact and we can try and organise a time for that education to occur within your practice. So that's my big plug. Now we've got sort of 8 or 10 minutes before we finish, so that's the end of the slides. So I don't know if there's any burning questions that anyone would like to ask.
So we haven't had any questions come through, but I just wanted to say that really, really impressed with what you girls have put together. Really passionate about it, and I think that everyone can easily get behind this being a, you know, a great program. And I don't think, yeah, I'm not sure if any questions will come through. So I guess everyone can have an early mark, which doesn't generally happen. But thank you again to Alison and Alana for presenting today. Really appreciate it. Yeah. All right. Well, thank you very much. Take care.
Thank you.
Thank you, and please contact and we'll do the extra training, because it's an amazing program and we want to make sure that we keep the funding for it. So we're really keen for you guys to be using Alana and to be looking out for it and to be using the service. So I can't stress that enough.
Thanks, Alison. Thanks, Alana.